you very much. It's a real honor to be here. I want you to know that my suggestion for this lecture did not come from Dr. Irvine. I've had the great fortune of being asked to give several named lectures at many prominent institutions. As a tribute to the institutions, I've presented them with a gift, and that is to shine up a mirror and to allow individuals to see the meaning of their own institution. Too often we don't understand where we come from because we're inside. I gave the Hogan lecture discussing the impact of UCSF ophthalmologists in our study of glaucoma. I had the great privilege in 1999 of giving the Doheny lecture and focused on contributions of U.S.C. ophthalmologists, the Braley lecture from University of Iowa, and of course there are many, many wonderful glaucoma specialists from Iowa. I gave a tribute to Doug Anderson as the Norton lecture in 2001, the Saul Sugar lecture, which was phenomenal for me to view what contributions had been made by him. The Cass lecture in honor of Mike Cass, and the wonderful group from Washington University, St. Louis. In appreciation of this lecture, I'd like to present John with a couple things here. This represents a printout of every publication of both you, your grandfather, your father, and your uncle. Because I know nobody uses that, it's also here on this stick. I'm sure that they will probably find their way to a dustbin like almost everything has in the libraries, but Dennis Bermuda is our research librarian, has just done a wonderful job in helping me track down every publication from you, your grandfather, your uncle, and your cousin. My purpose is really to focus on the enormous contributions that the Irvine family has made now for over 70 years, not only for research, education, and patient care, and also to focus on what I discovered is a most unique relationship between the Irvine family and not only the Doheny Eye Institute, but the UCLA Department of Ophthalmology, a fact which I'm sure Dr. Stratzman is very, very well aware, but many of you may not be. So which Irvine are we talking about anyway? Let's see, there's A.R. Irvine. That could either be Alexander Ray Irvine, or after the birth of his son, Ray Irvine Sr., or his son Alexander Ray Irvine Jr., or A.R. Irvine, meaning Alexander Rodman Irvine. Fortunately, S.R. or Samuel Rodman Irvine did not have anyone I was confused with. W.C. Wendell Cannon Irvine, who was just mentioned by John. John J.A., and I'm very happy that he was not another A.R. Irvine for the purpose of tracking down information. And then lastly, Mary Daly Irvine, who was Rodman Irvine's wife, a great friend and advocate of Estelle Doheny, whose friendship and support led to the founding of the Doheny Eye Institute over 50 years ago. So who was the patriarch? That would be Alexander Ray Irvine, the son of two Scottish immigrants who found their way to Utah. He was born in October 1879 and passed away in April 1967. I also should pay tribute to the archivist from University of Pennsylvania, a School of Medicine. When I called the College of Physicians in Philadelphia, I said, can you tell me about the Medico-Chirurgical College? And they said, well, let's see, that was subsumed by University of Pennsylvania in 1926. And I said, is there a yearbook available? I'm trying to find out some information on a Dr. Irvine, whose name lecture I'm going to be giving. They said, well, let's see what we could find. And this is the Medico-Collegian, the yearbook of that college from 1906. And there is a strikingly handsome A. Ray Irvine. Quote, he was a man, take him for all in all. I shall not look upon his like again. And you will, I think, come to realize he made enormous contributions, not only through his own work, but that of his progeny. He graduated from Logan City Agricultural College in 1883, which is now known as Utah State University. He traveled in Europe and he entered the college, and he was a member of the Rodman Surgical Society. More on that name in a moment. I dug further and contacted Utah State University, and this is a publication from the Alumni Association. U.A.C. stood for the Utah Agricultural College, and it describes what he did after his tenure there as a student. He taught at Cache Junction. He then traveled throughout Europe. He had a 30-month mission there, and then returned to Salt Lake, and then shortly to Philadelphia, where he went to medical school. So he had an illustrious past, and I was surprised to realize he had spent some time, like many people, passing through Wills Eye Hospital for postgraduate work. He also visited the University of Vienna. He was a founding member of the Salt Lake City Eye Clinic, a captain in the United States Army Marine Corps, and was president of the Pacific Coast Ophthalmological Society. He subsequently moved to Los Angeles. He was one of the founding members of the Research Study Club of Los Angeles, a group for whom I've had the privilege of lecturing. He became president of the Los Angeles Academy of Medicine, and he was clinical professor and chairman of the section of ophthalmology at the beginning of the University of Southern California School of Medicine. This was a tribute to him in an obituary written by Warren Wilson in the Trans-Pacific Coast Oto-Ophthalmologic Society, and I couldn't think of a more wonderful comment that anybody might make in the event we pass on, that Dr. Irvine was more than an outstanding ophthalmologist. He was a pleasant, friendly, and outgoing person. His ability to reassure an anxious patient or relative was recognized by all who worked with him. Though inactive, the past few years his help was often sought, and his good advice accepted by all of us who now miss him so much, especially those who trained under him and remember him as the chief. That's also what we referred to Dr. Norton. Wonderful words, and notwithstanding how we will be paid in the future, I cannot help but think our patients will all highly value these attributes which were described in his obituary. Now, you probably didn't know that he's also recognized in another way. If you are walking down Disneyland's Main Street and look up above, you will see the name Alexander R. Irvine, M.D. And in fact, this was a tribute by his personal physician, by his personal patient. He was the personal physician of Walt Disney. And there appears the name of Alexander R. Irvine. This was actually above the baby care center. Now, I know Disney is very peculiar on having everything right, but I highlighted the misspellings when I went to this, and there can see ophthalmologist is misspelled, and then I have to update that John A. Irvine is affiliated with U.S.C's university. So I will change that and notify them that there are some corrections to be made in their description of the name of Alexander Irvine. This is a wonderful quote. This came from JAMA in 1950, and I'll just paraphrase. The last 50 years have been characterized by tremendous progress in the basic sciences, in the development of medical research and organization of teaching facilities, and in the availability and utilization of these accomplishments by virtue of superior transportation and communication. He goes on to extol the virtues of the slit lamp and the ophthalmoscope. I couldn't help but wonder what he would think if he were in the audience today and heard the phenomenal progress that we've all experienced between 1950, midway through the 20th century, and this year. So in that description of where we are, or where we were at mid-20th century, I can't help but again value these words. Your attitude toward every patient you see in your office, in his home, or in the hospital is influencing the trend and determining ultimate outcome. If yours is an attitude of concern only for the welfare of the patient, there will never be a system of socialized medicine. This was, by the way, before Medicare was adopted in 1965. The absolute attainment of this attitude, like religion, is not acquired without effort. It must be ever taught, practiced, and publicized. Well, this is his son, John's father, Alexander Ray Irvine Jr., and he passed away in 1996. He graduated from Stanford, was at U.A.C. He did an internship at University of Chicago, and then ophthalmology residencies, like so very, very many people of that era, at Mass Eye and Ear, and he was a visiting fellow at the Wilmer Eye Institute. He joined his father and his brother, S. Rodman Irvine, and cousin Wendell here in private practice. He went on to be a key factor in the establishment of the Estelle Doheny Eye Foundation. He was the first ophthalmic pathologist at the Doheny Eye Institute and served as its medical director, and the laboratory was named in his honor for his dedication and expertise in pathology. Narsing wrote a beautiful, beautiful editorial, or obituary rather, that appeared in the Transactions of the American Ophthalmologic Society. Sandy was a humorous and generous man. He was sincerely interested in his patients, dedicated to the ophthalmology students he taught and his colleagues. He was always honest with his patients and straightforward with his colleagues. He was an emeritus member of the Verhoff Society and an emeritus member of the AOS. I can't help but think, again, these values will continue to be highly regarded by our patients and our colleagues, notwithstanding whatever threats our income might face in the future. John, Sandy's son, went to med school here. He did an internship at LA County. He was again at Mass Eye and Ear. He did a cornea fellowship there. He's been on the faculty, and he is now medical director of the Doheny Eye Centers at UCLA. This is S. Rodman Irvine, the brother of Sandy, and there's a wonderful obituary written by Dr. Strotzman that appears in the Transactions of the American Ophthalmologic Society, discussing his enormous contributions to the development of ophthalmology here in Southern California. Now, I must tell you, when I looked for Rodman, I was a bit surprised when I just had, his name there. Apparently, Dennis Rodman, some of you may recall, there was a former hoax that he may have been killed. And I was pretty sure that wasn't the right Rodman that I was referring to. And I came to realize that the Rodman that was the reason for the name of S. Rodman was William Lewis Rodman, a Kentuckian, a physician who went to Philadelphia. He became the chair of the medical school where A. Ray Irvine Sr. graduated. He was a member of the national establishment. He was a founder of the National Board of Medical Examiners, and he was also a president of the American Medical Association. Therefore, the name the Rodman Surgical Society, and I'm sure in respect to his mentor, S. Rodman bore the name of Lewis Rodman. So Rod Irvine attended Stanford. He went on to Harvard. He performed rotating internships in Boston. He did a residency at Mass Eye and Ear. He spent time abroad in India with Colonel Wright, who was an ophthalmic surgeon, and I suspect he had a chance to see filtering procedure developed by Colonel Elliott. He was a major in the United States Air Force, where he served. He had a most illustrious academic career. He started out at University of Southern California. He was a clinical professor of ophthalmology. He was actually then at UCLA an acting chief in the Division of Ophthalmology and clinical professor. Sandwiched in between there, he did a sabbatical at the Wilmer Eye Institute, where he had a chance to revive interest in cataract surgery, its complications, and the development of uveitis when he was in Baltimore. He retired in 1977 from surgical practice, at least for a while. He then returned as a clinical professor of ophthalmology at UC Irvine, and the crowning achievement, I think, was the Lucian Howe Award from the AOS. The UCLA Department of Ophthalmology still rewards a prize to those who exemplify teaching in honor of his contributions. This obituary, which appeared in the then Archives of Ophthalmology by his son Alexander, or Alex Irvine from UCLF, describes his father. He was not a dilettante, but rather was at the forefront of knowledge, publishing in peer-reviewed journals in each field. And I think this is a great quote. He believed that careful study of patients in a private practice often provided the best laboratory and source of new knowledge. He was a true Renaissance man in ophthalmology at a time and in a way that we can only admire and envy. Wonderful, wonderful words from a father to a son, from a son to a father who made great contributions. Now, there's one Irvine I could not go without mentioning. You'll say, well, I don't know who Richard Irvine was. Well, it turns out Richard was Sandy and Rod's brother. And for any of you who have ever sat through It's a Small World After All at any Disney location, you should know that Richard Irvine was the brainstorm behind Walt Disney Enterprises. He was hired by Walt. He was a key factor in the development of the Disneyland here. Before his untimely death, he assumed a large role in the development of Disney World in Orlando, Florida, and he was really the vice president and COO of Disney Enterprises, also known as Imagineering. And I thought that was an interesting comment on how everyone has had a lasting impact, not only on eye care, but on how people enjoy life, particularly with their children. So the last Irvine is Alex. He was the son of S. Rodman. He did a retina fellowship at Baskin-Palmer. He was on the faculty at University of Florida, and he remained at UCSF until his retirement. There's virtually no aspect of retinal care, surgery, or diagnosis that he did not describe. He had a major role in the initial description of AIDS-related infections in the eye, fungal endophthalmitis, the use of pneumatic retinopexy, phototoxicity in the operating room, and several publications on uveal melanoma, all of which are included in that 3-ring notebook. So I will reflect my bias as an editor. We'll talk a little bit about S. Rodman Irvine, and on a condition that I thought I understood, cystoid macular edema, some words on A. Ray Irvine, and an interesting connection, which I think I've made, between a publication of A. Ray Irvine, Jr. and one of his sons some 30 years later. So I get the first question is, well, whose syndrome is it? When I started, I figured, well, it must be, let's see, Don Gass was in Miami, it must be Alex Irvine, right? You know, and it wasn't, in fact. There's a couple things that are interesting. I pulled a Stedman's off the shelf in my office. It was published in 1972, and you will see Irvine's syndrome, edema of the macula that occasionally follows cataract surgery. A couple things that are interesting. You will notice the apostrophe S with this eponym, and that has since been dropped. I went to the library and the 2000 Stedman's, and it is now Irvine-Gass syndrome, macular edema, aphakia, vitreous humor adherent to the incision for cataract extraction. So I often wondered, well, how did that evolve? Well, it turns out that the original description of the Irvine syndrome was as the 7th Francis Proctor lecture in 1953. And I think it bears what we would all regard as clinical cystoid macular edema. And it's interesting because Rod Irvine was very specific. The complication, you'll read what he refers to, is that of late rupture of the anterior hyaloid face. This is not associated with vitreous loss at the time of surgery. It was also characterized by postoperative macular changes, ultimate reduction in vision. And he writes here, it is to be emphasized that the adhesions which are the essence of the syndrome are not noted until weeks or months after surgery, that it is rare, and that effect on vision in most instances is only an annoyance. And there are wonderful pictures I will show, or drawings of the condition. We were talking about how many cataract surgeries are done. This represents a 16-year compilation from 1936 to 1952, and although we might do this with a flick on an Excel sheet or a keystroke, this represented an enormous collection of data in a private practice setting. There were 1,068 over 16 years, so they were doing about between 65 and 70 cases a year. And you will see down here at the bottom, 73, late rupture of the anterior hyaloid face with adhesions to the wound. And this is what they look like. You'll see here these strands that are attached either circumferentially or as discrete bands to the wound. And that was felt to be a key factor in the development of this condition. So what happened? How did gas get involved? Well, the rest of the story wasn't told until 13 years later. It was 1966. Novotny had described fluorescein angiography, and JDM gas, at that time only an invitee by Dr. Norton, presented fluorescein studies in patients with macular edema and papilledema after cataract surgery. And it was also described in an article in Archives of Ophthalmology at about the same time. And for those of you who knew Dr. Gass, you can almost hear him very sheepishly say, we certainly don't know the etiology of this syndrome. He goes on to opine, I think it is interesting how different people can look at the same patients and see different things. I believe it points up to the difficulty in the examination of the posterior part of the eye. We certainly feel the vitreous must play an important role in the development. We also admit that a process of traction in a few cases, it can cause loss of macular function. However, the key point he makes is that in none of the patients that he observed CME did he see vitreous traction in the macular region. And he goes on to describe that he really isn't sure how you can tell if people are going to get better or not, or how to determine the prognosis. And most of them get better, but some of them don't, and they've had a chance to follow patients for almost 2 years without any improvement in vision. And I can hear him say, not improved one iota. So this is an artist in interpretation. J. McGinnis Myers, a retired medical illustrator, moved to Miami in 1966 and died in 1968. For any of those who've ever seen Berliner's book, some of you, it's marvelous. It's illustrated. The 42 plates that were done by Myers have been reproduced in a book that recently was published by Reva Hurtis and Dick Forster. So that's a gift to the department from Baskin Palmer, and it shows this wonderful drawing of macular edema. And again, this was done by someone looking in the eye and working with Dr. Gass. And we see here what we would describe as typical petaloid cystoid macular edema. The difference was Gass was not convinced that the integration of vitreous into a surgical wound was necessarily related to the pathophysiology. Now this I have to show you. This was the original transactions of the American Ophthalmologic Society by Gass and Norton in '66. And you'll see this late staining. And here we are in Archives of Ophthalmology, and I said, gee, I'm not sure, but wouldn't we call that duplicate publication? And I think nowadays with the proliferation of everything available online, it makes you realize that there was a time when the number of individuals receiving the transactions of the American Ophthalmologic Society were very few, perhaps a couple hundred, and they resided on dusty library shelves. Most of the world did not have access to that. So these are, in fact, this is the exact same patient which is described twice. And that wasn't so long ago, 1966. I don't think there was anything duplicit in that, simply a way of providing information to individuals who did not have access to the transactions. So there were further studies, and this is a very, very interesting paper that appeared in AJO in 1955. It's a further discussion of this late rupture of the anterior hyaloid face, and this is by, again, Rod Irvine, and he describes these anterior condensed transparent strands of vitreous coming forward and attaching to the wound. And I think that's something that we see now if wounds are not properly maintained or cleaned after vitreous loss. But what I found was most interesting is this is the first description, and I'm sure there are others, of what we would regard as the precursor to pars plana vitrectomy. He's describing patients who have vitreous blobs in the anterior chamber. And so he said, you know, if we stir up the vitreous and inject air into the anterior chamber and create a posterior sclerotomy and the foreign vitreous is forced out of the wound, you can push vitreous out of the eye, improve vision. And this is well before Mockamer or Perel or anyone, to the best of my knowledge, had proposed vitrectomy as a way of removing a blockage to prevent images from falling on the retina. So this was, I thought, just stunning. And he writes here that it's important that the formed vitreous be brought out the eye. Of course, we're thinking vitreoretinal traction, you know, retinal tears. And he says the vitreous fistula is apparently created, altering the flow of vitreoid aqueous. And so basically the vitreous is sucked back, it's pushed out of the eye, and the axis is cleared. Remarkable. To Dr. Irvine's credit, however, he did not claim that he was the first one to do this. Let me go back. In fact, it had been, there you go, fast. It had been described by Brendan Leahy previously, and this was for the treatment of what was known at the time as bullous keratopathy, in which a cyclodialysis spatula was used to sweep the vitreous from the eye, create a posterior sclerotomy, and then to force it through. They also describe that if you put too much air in the front of the eye, you can create an acute pupillary block, and the treatment can be done by letting out additional vitreous. Again, remarkable, the finding that if you left vitreous in the anterior chamber, you would see small bubbles rather than one large round bubble. And I think we were all taught that at some point when managing repair of scleral wounds or after trauma. If there was residual vitreous, you would not see one solid air bubble in the anterior chamber. This was just an example that was given of clearing the vitreous with this rather unusual pars plana, I guess, vitreous removal. So it's hard to imagine how these publications came to be at a time when paper was so expensive to print and send. If you were asked to write an annual review for the Archives of Ophthalmology, that was a big deal. The article that was published, and Sandy, A. Ray Irvine Jr. did too in 1960 and 1961, again sounding very, very humble. He hoped that this information would be of sufficient interest to the busy clinician, at the same time appear to the laboratory investigator. The idea that he could achieve both was unthinkable. So this was a 20-page printed commitment in 1960 for the first review, and one almost as long the next year. We were talking about cataract surgery with wounds that weren't sutured. Well, he makes reference in a very humorous way to a publication by Norval Christie, an ophthalmologist in India, who did a bit of a study, and this was well before I think the RCT eponym for randomized clinical trial was known. So the question was, how bad is it to get people up out of bed? And this was in India. They did 1,000 people who were put to bed rest for 8 days, 1,000 for 1 day, and 1,000 walked out of the operating room. Now, you know, they looked at anterior chamber formation that was delayed, and Dr. Irvine comments, this just might have been entitled, "Why Use Sutures in Cataract Surgery Instead of Ambulation in Cataract Surgery," which I thought was a pretty telling way of saying this was not a very well-designed study. There's two interesting things as I finish here. This was a publication in Archives of 1975 in which A. Ray Irvine describes a man who had undergone a nasal pterygium excision in the right eye with a bare sclera technique, and I bet I'm not the only one at some point in their life who used a beta irradiation treatment after a pterygium excision. And he describes noticing a small dark spot, and it would become less dark after artificial tears were used. And this was that man in 1975, after the pterygium showing the area that desiccated. Out comes the water. You can see through the sclera looking at uvea. When you put on lots of artificial tears, it looked better. And that was in 1975. Well, John, has written a great deal on the anterior segment. He described anterior segment optical coherence tomography after corneal and scleral melts, as well as a finding of surgical debridement for infectious scleritis. But this is the article that I was most struck by. This is a patient that was described in 2007 by John, and it shows somebody who appears to have had pterygium surgery. And when you go on to read the description of the article, they'll show that area of thinning. And there was a scleral melt associated with beta radiation. There was a calcium plaque, and they go on to describe this thinning in the area, presumably underlying the zone of previous beta irradiation. And in fact, it was a 65-year-old man who had had beta radiation in the distant past. He had undergone an alizarin red stain to excise the plaque. It was calcium. They put on fibrin glue and an amniotic membrane and an epicardiograph. It sloughed, and he ultimately ended up doing a pedicle conjunctival rotational graft, which resulted in resolution of the problem. I could not help wonder if that patient, who had been described some, I guess, nearly 19 years earlier by John's father, was the very same patient that he had the opportunity to operate on many years later. And that was, this is not proof, but it certainly suggests that it might be the same individual. What you see on the right is the OCT demonstration of the resolution of the problem. John also described, scleral thinning that was associated with infectious keratitis or infectious scleritis, again after pterygium excision. I think if all of the previous Irvines were here with us today, they would smile and think how far things have come. An article that was published recently on the prosthetic replacement of ocular surface ecosystem with scleral lenses, to me, is nothing short of remarkable in these patients with the most difficult graft versus host ocular surface disease. And this report came out not too long ago, focusing on patients with graft versus host disease, and the fact that they were able to enjoy an improvement in visual acuity in a condition that had been recalcitrant to virtually every other intervention. And if a picture is worth 1,000 words, then I think this certainly demonstrates the effect of this PROS system, which would be simply fantastic and unthinkable at a time when both Rod, Sandy, and their father were practicing ophthalmology. Well, in summary, I don't think the acorn falls far from the tree. The innovation that has been provided by the Irvine family in virtually every aspect of ophthalmic care, education, and research has been a joy to review. I hope you treasure it, and in listening to every presentation that I've heard today, I can tell you that their spirit is alive and well here at the Doheny Eye Institute. Thank you.